And I don't want to risk stepping on our speaker's toes, but I can tell you that the board did meet last night, and we've talked about, you know, is there more that we should be doing to keep our members safe related to COVID? And so we'll probably be reaching out to all of you again to get your impressions of how things are going and any steps that you think we need to be taking before we change the way that we're meeting. And so we're certainly, as the rest of the world is, constantly looking into that. But I'm not the expert on this. Someone else is. And so Sharon, would you be willing to come up and introduce our speaker for today, please?
I'm happy to say when I asked Dr. Ludlow to be our speaker today, he quickly agreed to do that for me. He's a charter member of our club. You probably know that. I asked him for one thing you might not know about him, and it's he only lost one game in high school, Shawnee Mission South, is that right? The last game of the year, and it was a tournament or
state championship.
State championship. So please welcome Dr. Ludlow.
Yeah. This turns up or not up. You can hear me. I hope you can hear me. Can you turn on the gallery view real quick, Mark?
Sure.
I was just noticing in the gallery view, where did John Mosley, yeah, where did he go? He was here a minute ago.
There he is.
Oh, there he is. Okay, there he is. He had a sunset behind him earlier, and now he's in front of a glacier. I don't know what trip you're on, John, but I want to join you in the worst way.
Love to have you here, Mike.
What did he say?
I think it went to Antarctica.
Antarctica. He's in Antarctica now. Okay, great. For those of you who don't know my background, I graduated from Newman University in 1978. Went on to KU Med School, graduating in 82, and then did my residency at St. Francis Hospital, now Via Christi Ascension. Finished my training in 1985. I've been at West Wichita Family Physicians in private practice since 1985, and we have grown to a total of 29 physicians, all family physicians in one location. It's been a privilege to work there my entire professional career. We have about 130,000 active charts, which is counted as a patient who has seen us at least once in the last 3 years, so it's a big practice. Today I thought might be interesting to talk about something that be on people's minds like COVID-19. So I'm going to do that and then give you a few fun facts about West Wichita that you may not know, the family practice clinic that I'm a part of. COVID-19 is the worst pandemic since the 1918 Spanish flu epidemic. For those of you who don't know, Spanish flu started in Spain when the Big Red 1 Army unit deployed from Fort Riley deployed to Spain with a soldier from southeast Kansas who carried the influenza virus with him. And then he infected other people in Spain, and they gave them credit for the pandemic when in fact it came from a soldier from southeast Kansas, went through Fort Riley, and then deployed to Spain. The world experienced an estimated 500 million cases of flu that year, affecting a third of the world's population at the time. Death tolls estimated at 20 to 50 million people, including 675,000 Americans. Spanish flu was an influenza virus, which is known for mutating every few years. In 1980, the virus just became a lot more deadly and was much more prevalent. In an average flu season, there are more than about 200,000 people hospitalized in the United States, and the death tolls range from around 20 to 40,000 per year. During the Spanish flu of 1918, the average life expectancy actually declined 12 years due to the virus. Vaccines have greatly reduced the severity of the influenza outbreaks, but the CDC currently seeks an efficacy rate of 40 to 60% for their vaccine. So in a good year, they're 40 to 60% effective. So if you get a flu shot and it's 40 to 60% effective, they say, boy, we know that like a carpenter, we're all over that like a rat on a Cheeto, we did it this year. In 2017, 18 flu season, they had a 28% effectiveness rate for the vaccine, and there were 55,000 deaths in the United States that year. The following year, in 2018-19, the effectiveness rate was 48%, and there were only 28,000 deaths, but still 28,000 deaths related to flu that year. The past 2019-20 flu season was relatively vigorous until the COVID-19 pandemic emerged in March. And when it did, with quarantines and masks and social isolation that people started with, the flu epidemic died. 1 week to the next, it just died. It went away. This is the backdrop against which we should now look at COVID-19. There have been, as of yesterday, there have been 1,325,085 deaths worldwide, and the 251,901 deaths in the United States. The death per population in millions have been recorded and show the United States is 13th in the world in mortality. Notably behind multiple South American countries, Mexico, the United Kingdom, Spain, Belgium, and Italy. As you may know, the US leads the world in total tests performed to date, so our statistics are likely a little more reliable than a lot of the countries that we are receiving data from. So you always have to be skeptical of data when it comes from countries that aren't recording data. Sadly, there's still too much we just don't know about the COVID-19 virus. They call it novel for a reason. It's new and it's different, and we're learning as we go. The virus first appeared in Wichita that they could identify and actually do scientific testing for in March. There were people who were pretty convinced they had it prior to that, and some of those that I've tested have tested positive. Most of them have tested negative. So for the most part, it arrived here in March. It has sort of waxed and waned through the spring, summer, and fall, but it is about white hot right now for the past 3 weeks in Wichita. It's currently the worst it's been since the pandemic started here in Wichita. At West Wichita Family Physicians, we are performing a rapid nasal swab test now, and the positivity rates, that is the number of positive results per test run, have ranged between 30 and 54% in the last 2 weeks. We've been able to do over 100 tests per day, and the demand has been the most it has been since the pandemic started. To date, I've not had a patient of mine die from the disease that I'm aware of. I had one patient who was placed on a ventilator. 2 weeks later, she was extubated, went home 2 days after that. She had renal failure, congestive heart failure, diabetes, African-American ethnicity, and poor judgment when she refused admission in the ER at Wesley when they told her she should be admitted. They called us and said, you need to arrange for oxygen for her, which we called to do. And I said, tell her she needs to be in the hospital. My nurse told her, you really need to be in the hospital. And she said, well, if I don't get better, I'm going to go in tomorrow. And he said, you really, there's things they can do to help you. You should go in today. Well, she said, if I don't get better, I'll go in tomorrow. And then I got her chest x-ray result. It showed all 5 lobes of her lung. You only have 5 lobes in your lungs, and all 5 lobes were full of pneumonia. And I said, I called her at 5 o'clock that afternoon, that evening, and I said, you really need to be in the hospital. And she said, well, if I don't get better, I'm going to go in tomorrow. I said, seriously, you could die at home tonight, and you really need to be in the hospital. There's things they can do to keep you off the ventilator. If you get on the ventilator, there's an 80 to 85% chance you're going to die. She said, well, okay, Dr. Ludlow, if you think I should go in, I'll go in at 8 o'clock. Apparently she had to watch Wheel of Fortune or something. I'm not sure what. But she went into the hospital and coded in the ER, and they put her on the ventilator. So I kept expecting to read about how she had died from her disease. And 3 or 4 days later, I got a chest x-ray result that was showing improvement. And somehow, some way, she survived. So that's the closest I've had to someone dying from it. She is on dialysis now. That's a consequence of the virus, how it affected her heart pumping function and her kidney function. It affects multiple organs in your body. It's not just your lungs. So when they've done studies on chimpanzees, they infected on purpose with this and found the virus to be widespread in almost every organ in your body when it's affecting you. So it's a very bad virus. Treatment for the disease has improved pretty dramatically since March when we first started with it. The experience-based learning curve is changing what we know about the disease and what is working and what's not working. Patients were placed on ventilators too soon early in the course of treating the disease, and too many of them died. We've learned other ways to manage the disease early on that are helping us to avoid placing patients on the ventilator, which carries a mortality rate, as I mentioned, of 80 to 85%. Proning patients is where you lay them on their tummy and actually helps with their breathing. Seems counterintuitive that would help, but laying them on their tummy helps with their breathing somehow. So when they get to the ER, if they're struggling to breathe, rather than jumping to a ventilator, they put them on their tummies, and many people's breathing improves almost immediately when they do that. So proning has been a thing they started out with in New York City, and it's been across the country. People have been doing that. The use of remdesivir, which is an AIDS treatment, convalescent antibodies, dexamethasone, and a lot of the respiratory care algorithms have changed. They were using aerosol treatments where you would breathe the puffer and all your aerosol will go out the room and through the ventilation system, infect other patients in other rooms. So they've decided aerosolization of the virus is a bad plan. So they're using inhalers now instead of the aerosol treatments. You have to be in a negative pressure room to use an aerosol treatment. So that has changed. And the convalescent antibodies, for those of you who don't know, that's an antibody from someone who has had the disease. They harvest their plasma and then they give the plasma to the individuals who are suffering from the disease currently, and it gives them antibodies they don't yet have to fight the virus and try to do well. Death rates are declining, but at the same time, infection rates are increasing. So it remains a much more dangerous disease for the elderly patients, and particularly people with comorbidities such as heart disease, emphysema, COPD, asthma, diabetes, and any sort of compromised immune status that you might have from cancer therapies or immune suppression for things like rheumatoid arthritis or lupus or that sort of thing. Alternative treatments as an outpatient to prevent hospitalization are many, and some are quite controversial. Hydroxychloroquine has been touted as the cure early on to the most dangerous thing you could possibly take, depending on who you were listening to. I've reviewed the literature and tried to separate fact from fiction, and my take is that hydroxychloroquine is not a dumb idea early on. That's the key. Other things like vitamin D3, zinc, vitamin C, and some steroid inhalers have been used as an outpatient basis and are less controversial. They've helped keep people at home and keep them off the ventilators. Aspirin, like a baby aspirin, has been used in an effort to thin your blood. One of the things that COVID-19 is causing is an increased coagulation in your bloodstream, that it can increase your likelihood for blood clots that can go to your lungs and what they call pulmonary emboli, so little blood clots that go through your heart and out to your lung. And as the vessels get smaller and smaller and smaller, eventually it will plug an artery. And when it does, everything beyond that spot in your lung will die. So that pulmonary artery supplies a vascular circulation to the lung that will not survive. And you have a short period of time to correct that before it becomes a permanent problem. So if you have multiple of these pulmonary emboli, people can die from that as well. So aspirin sometimes has been helpful in helping prevent that by reducing the risk of blood clotting. Worsening symptoms during the illness generally peak at around 5 to 7 days. The use of hydroxychloroquine early in the illness has been associated with a reduction in mortality rates of up to 50% in the Henry Ford Health System study. Death rates remained extremely low in that study. They had, I think, around 5,000 people in the study divided into two groups, those who did and didn't get the hydroxychloroquine. And my recollection, I couldn't find the article last night when I was finalizing my remarks, but I believe it was 40 people died in the treatment, the people that did not get it, and 20 people died in the group that did get it. So in that study, there was a 50% reduction in the death rate with hydroxychloroquine use early on. It has no place in the hospital setting or later. People that are getting ready to go on the ventilator, it doesn't work at all. It's a terrible, terrible idea. Death rates remain extremely low for otherwise healthy people, but and most people do well without any treatment, to be fair. Other suggestions for care, as sent to me by our own Jack Flesher, is Jack on the Zoom call? I think he is. Was the consideration for an MMR vaccine in the older population, which is defined as over 60. Some evidence to support that includes lower infection rates and better survival among children and people under the age of 60. Children, you may know, get a measles, mumps, rubella vaccine at 15 months and again at age 5 years. It used to be 1, now it's 2. Older children and adults have had at least one vaccine at age 15 months, but most of them that are 30 and over only had the one vaccine. And so they could use a booster, perhaps, is what the CDC says. About 3 years ago, there was an outbreak of measles in our country in the Hasidic Jew community in New York. and that spread to Connecticut, and then by plane it spread to Wisconsin. So, and measles is one of the more contagious diseases out there, not dissimilar to the coronavirus in that regard. The CDC at that time decided that it would be okay for people under the age of 60 to go ahead and get a second dose of the measles, mumps, rubella vaccine. So we had I don't know if any of you did this, but a lot of people under the age of 60 about 3 years ago came in and got measles, mumps, rubella vaccines in an effort to prevent them from getting measles, because it was getting pretty hot across the country about 3 years ago. People over 60 at that time were felt to have had the disease. I had measles, I had mumps, I had rubella, I had all three when I was a little boy. And the thought was we have lifetime immunity from that. What they're finding now is that children have generally very minor disease with a COVID-19 virus, unless they have some other comorbidity that's more serious, like asthma or cystic fibrosis or diabetes or some other things. And similarly, adults under the age of 60 tend to do pretty well unless they have comorbidities. So people over 60 that aren't doing as well, generally speaking. And one of the theories about that is that perhaps the lack of measles, mumps, rubella vaccination is why they're doing worse. There was a study that was done that tried to figure out why that was. And measles shares 23% identical DNA to the coronavirus, and rubella, the German measles, shares 24% of an identical DNA to the coronavirus. So the theory is that the immune experience from the measles, mumps, rubella vaccine is helping you fight off the coronavirus more effectively, because you've seen at least part of its DNA before, and you may react against that and help recover more quickly, or perhaps even prevent its occurrence. There's a study at Washington University in St. Louis that's currently underway to determine if this is a good idea to treat or not until an effective vaccine for coronavirus becomes available. Safety of the MMR is well established, and even with adequate immunity, getting an additional shot would not be harmful. So those of you over age 60 who think about maybe doing that, you could check with your insurance provider, see if they'll cover it. A lot of them are reluctant to cover it because it's not been approved for that use, but there is some thought that perhaps it would be beneficial. The end of the pandemic, in my mind, lies in herd immunity, and that's either going to come through more people getting the disease and recovering from it, or it's going to come through vaccines, or it's going to come through a combination of the two. We have plenty of people getting it right now. Vaccines do appear to be on the horizon fairly soon. There's concern about whether you should jump in and get the vaccine. There's questions about whether we're rushing it too quickly, whether there's any long-term side effects from the vaccine. And when you're pushing to get through a vaccine this quickly, you're not going to know what happens 5 years from now when people who get it. So there is a little risk in that regard. There's also a risk of coronavirus. There are a lot of people dying from that right now, and there could be long-term consequences of getting coronavirus that we don't know about either. So I've heard people on the news say we should close schools. One death is too many. And I want to ask them, how did you pick up your groceries? Did you drive your car? Because if one death's too many, you should never get behind the wheel again. That's, we have to find some way to show the relative risk of things in life. And, you get out of bed in the morning, you put your feet on the floor, you might fall and break your hip. You never know. So everything we do in life is risky, and you have to really try to mitigate risk as best you can and take precautions against it. But you have to roll the dice every day to do something. Otherwise, poor Mark would never have anybody to see. There are 6 vaccines in development, 6 types of vaccines in development. There are over 200 vaccines being studied worldwide. The different types of vaccines are ones that target DNA and RNA-based vaccines, where you take fragments of the virus and develop a vaccine against that DNA and RNA that you inject into the person. They replicate the spike protein, for instance, it's on the surface of the coronavirus. And rather than giving you the virus, they give you the spike protein that you can now develop antibodies against. So if you're exposed to the virus, you react against that. There are 2 mRNA or messenger RNA vaccines in production right now that you've heard about recently, the Pfizer vaccine and the Moderna vaccine, both of which are greater than 90% effective in creating immunity. They should be released here in the next few weeks. They should start to be rolled out for, my understanding is, going to be healthcare workers and the elderly at first, nursing home patients particularly, and then it'll ramp up and be millions and millions of doses probably worldwide available. They can be developed quickly. That's one of the reasons they're first out of the chute, is that the DNA and RNA are known within a few weeks of the virus breaking out in China. The DNA sequence was known. So within a few weeks of studying it, they had a vaccine ready to be tested. So that was one of the quickest things that could be done, was an mRNA and a DNA-based vaccine. They can be easily manufactured, produced cheaply, and they do not cause the COVID-19 when you give it to people. There's a theoretical possibility that the DNA could integrate into your genome, so that's a risk that you run if you get that vaccine. The Pfizer vaccine has to be stored at -70 degrees Celsius, which is a little bit of a complication for people trying to store the vaccine till you give it. You have to have a special refrigerator that apparently costs around $8,000. The Moderna vaccine only needs to be stored at -4 degrees Celsius, so it's much easier to get refrigerators that will keep that properly chilled. Second type of vaccine is a viral vector vaccine. They take adenoviruses or other viruses such as the common cold viruses and adenovirus, and they attach they use that to infect your cells with a little bit of antigen, and then that creates antibodies against that. The problem with that can be that if you already have adenovirus protection, you may not get the immunity that you're after for that vaccine. Advantage is it's a one-shot vaccine. The other two that I mentioned earlier are a two-shot vaccine so far. That's what they do so far. This one that is in development is the AstraZeneca vaccine that has been talked about as well, and it is in phase 3 clinical trials as well. So it should be available soon, and they think if it works will provide longer-term immunity than perhaps the DNA or mRNA-based vaccines. You can have what they call inactivated vaccine, which is where you take the virus and inactivate it and then inject it into a human to create immunity that way. Polio virus is an example of one that we've done that with. It does require more booster shots with that one. You can do a live attenuated vaccine. Polio and measles have that, where you, again, take the virus and it's a live vaccine, but you make it where it's not infectious, except perhaps to people that have immune compromised states. So there's some risk of getting the infection if you're on chemotherapy or you're on therapy for certain arthritic conditions with immune modulators, or Crohn's disease or ulcerative colitis or other things may be an issue for that. So people with weakened immune systems, there are some safety concerns for them with that type of vaccine. There's a proton subunit vaccine. I don't know as much about that, to be fair. They're developing that one in Queensland, Australia, and it has been a potent one. They think it's going to take longer to come out. It's probably going to be summer before that one is available. They're moving into phase 3 clinical trials soon. They have phase 1, then 2, and then 3. 3 is where you do thousands of people and test it. The Moderna vaccine and the Pfizer vaccine have both been through phase 3 clinical trials with over almost 40,000 people in each study. There's been one reported adverse event in the Pfizer trial that paused the trial for 2 weeks, but that got cleared and they moved ahead. Moderna's not had any problems in their study that I'm aware of. Ultimately, we're going to need multiple choices probably on these vaccines. And the good news is there are about 200 in clinical trials across the globe right now. So we should hopefully find some that work pretty well, and hopefully they can ramp up to do that. That's it about COVID-19 that I wanted to tell you today. I was going to briefly talk about West Wichita Family Physicians. I got a couple minutes?
Got a couple more?
Couple more. I'm sorry to run late. We have 29 family physicians, board-certified radiologists, and services that include 2 MRI machines, CT scanner, 4 $250,000 sonogram machines, 2 tomographic mammogram machines with computer-aided detection to detect breast cancer, stereotactic breast biopsy to rule out breast cancer once you've identified an at-risk lesion, nuclear imaging, cardiac stress testing, and bone densitometry to rule out osteoporosis. We have a minor surgery center where we offer upper and lower endoscopies to look for colon and stomach problems, and have anesthesiologists that can do epidural steroid injections for neck and lower back pain if that's appropriate. A radiologist has been doing a lot of interventional stuff that most of you may not be aware of. If you have a trigger finger where you can't get your finger straight, he, under sonographic guidance, can find the cyst that's in the tendon, break it up, inject it with cortisone, and you go home moving your fingers like you're supposed to. He's also done carpal tunnel release through a tiny little incision. They put an instrument underneath under sonographic guidance, turn a little crank, they deploy a scalpel basically that cuts the flexor retinaculum from the inside instead of having a big surgical scar on your wrist. It's a tiny little hole in your palm, and then it goes backward, and they cut the flexor retinaculum with that. I talked to him the other day. He said, hey, I did a carpal tunnel this morning. How long do you think it took me? And I said, well, you're getting so good, probably 10 minutes. He said, 4.5 minutes. I'm like, really? No, just local anesthesia is all it is. No anesthesia cost, no hospital operating room cost. It's just fascinating what he's able to do. He also does MRI guided prostate imaging and MRI guided prostate biopsies for prostate cancer. Instead of taking 12 samples of the prostate gland, which is the standard of care, what they call a truss biopsy, where you randomly biopsy 12 different areas and hope you hit something, he, under MRI guidance, can say, there it is right there, one biopsy. You have one pathology report for $125 instead of 12 for $1,800. So it's an interesting time in medicine, and I think what we're able to do in our clinic is pretty amazing right now. I've been very proud of what we've been able to do over time. Dr. McFarland is a nationally known speaker on MRI-guided prostate biopsy and imaging. He was invited to Colorado Springs to speak a year and a half ago. He was one of 2 speakers nationally to speak at that conference, and his lecture sold out in the first few minutes when it was posted for an offering. He's been doing the MRI imaging of the prostate and the biopsies for about 8 or 9 years now. Lastly, our COVID-19 clinic. We have a COVID-19 clinic that's run out of the south side of the building. There's an entrance that come in on the east side of the building through an emergency door. We've got it cordoned off with plastic so the air stays in that space. It doesn't go throughout the rest of the building. If you have COVID-19 and need to see a physician, we can have a physician see you in that of our existing patient population. We don't do it for just everybody. You have to be an existing patient, but we are able to do a nasal swab now that you get the results back in about 30 minutes. You have to have symptoms that are acute. You have to be between days 2 and day 6 of illness probably for that test to be accurate, but that test is about 99% accurate when it's done in that time frame. So it's extremely accurate, and we have 5 parking stalls in the parking lot. My parking stall is gone right now. We're doing COVID-19 testing in my parking stall. So they have 1, 2, 3, 4, 5. You call the number, you say, I'm in parking stall number 3. The nurse comes out to your car, will swab your nose, and then you get to go home, and we'll call and tell you if you do or don't have it. If you do have it, we're doing televisits with patients where we go through Zoom, or we go through FaceTime, or we have a Helio app on our computer system at work that if you log in through the portal, we can do it that way. But we are doing a lot of televisits. I think I did 7 of them on Monday, and I've got 3 or 4 today. So it's becoming a more common way for people to see the doctor, which is not my favorite way to do it, but it has been helpful for people to be able to see the doctor without having to actually come into the physical presence of other people who might have the disease. So it's been an interesting time, but we have not closed our doors since it happened. I'm very proud to say that. We've worked really, really hard at taking care of people, and our staff has been incredible. I give them all the credit in the world. So that's pretty much what I got to say today. Anybody have any questions?
If you were to get a vaccine, which one would you select?
Could you repeat the question?
The question is, if I were to get a vaccine, which one would I get? And I don't know that I have a favorite yet, in the sense that there's only 2 that have been phase 3 clinical trial about to get out of there and be approved for emergency use. My guess would be that I would take the Moderna one because it could be stored at a higher temperature, I should say. It's only 4 degrees below 0 instead of 70 degrees below Celsius. And messenger RNA carries a little bit more risk. If the AstraZeneca vaccine was going to be available a month later, I might wait for that. But people said, are you going to get it when it comes out? I said, yeah, mark me as first in line. I'm ready to go. I mean, this disease is nothing to play around with. It's serious business, and I'm tired of wearing a mask. I'm tired of not going to a football game. I'm tired of, not being able to watch fans in the stands and all the rest, and restaurants. Everything about it is just so disruptive to our society and our lifestyle that I sometimes joke I'm ready to either get the disease and get over it, have immunity, or I get the disease and I die and I go to heaven. Either way, it's not a bad thing. And I've had a good life, so if it happens, happens. But I'd probably do the Moderna one, but don't hold me to that. Any other questions? Jack, there you are.
I've been following a procedure lately that I wonder if you can approve
Okay.
in order to minimize the possibility of the virus. And that is, I've heard that alcohol kills the virus. Is that true? And if so, can I just drink more alcohol?
I think sanitizer will help, but drinking sanitizer will kill you. So probably that's the wrong idea. I did see a friend of mine sent me a sign that said the average golfer walks 900 miles a year playing golf, and he also drinks 22 gallons of alcohol a year. He said, so on average, the average golfer is getting 41 miles to the gallon. He said, it makes me feel like a hyper.
So, Dr. Ludlow, Deanne asks, what does it mean, risk it gets your genome?
Oh, against your genome, it means, Deanne, that it can incorporate into your DNA. The messenger RNA or the DNA-based vaccines could conceivably, and this is theoretical, change your DNA. So sometimes you have a treatment that's a quote biologic treatment like Humira for rheumatoid arthritis or for Crohn's disease or ulcerative colitis, and they always tell people that there's a slight risk of lymphoma when you take these treatments. So theoretically, it could change your DNA to produce a risk for you that you otherwise would not have had. But it's somewhat theoretical, and to prove that is always very difficult when you look at large numbers of people that took the drug and only a handful had a trouble. Was it the drug, or was it just unlucky, or there's so many variables that are hard to control for it, but they list that as a potential problem, and that's probably real, to be fair.
When people who don't seem to have any symptoms at all and are totally fine, but they tested positive, is there any results that there's damage to their organs that you don't know about because they had it?
Question was, is there any damage to organs of people who tested positive to the disease but didn't exhibit any symptoms? My guess is that, and this is my guess is based on an article I read about the cruise boat went out of Argentina, had somebody test positive 5 days into the cruise. They tested her little cohort of friends, and 5 of them had coronavirus. So they called Argentina and said, we want to come back. And they said, oh, you're a ship at sea. Too bad, so sad, can't port here. They called around Uruguay and said, we will take you, but you have to test everyone on board. So they tested everyone on board, including the passengers and the crew. They found 128 people had coronavirus. Of the 128 people who had coronavirus, 80% had 0 symptoms. So you can extrapolate that to mean perhaps that 5 times as many people have had this disease in the United States and around the world as we think, maybe more than that. So as far as people have no symptoms, do they seem to have problems? I haven't seen that clinically yet, but it's only been 8 months, 9 months. There are people that don't have the taste and smell that they lost come back like it should. There are people with chronic headaches, chronic myalgias, or muscle aches. Some people say their arthritis is worse. My patient who went on the ventilator, she's in kidney failure now, and she's getting better. They're hoping that maybe she can come off dialysis at some point, but there are variables, that are hard to control for. But younger people tend to be really tolerating it well. I did have 2 wrestlers that went to a camp in Mountain Ridge, or one of the M cities north of here, for a wrestling camp, and they got home and they got called that one of the campers had tested positive for COVID-19. So she called and said, I want my boys tested, about a month after they'd been exposed. And I asked if they had any symptoms. They have loss of taste or smell, fever, cough, chest pain, none of the above. I said, well, they probably didn't have it then. And she said, well, I really like them tested. And I said, well, if they had it, the antibody test would be positive. We could do that test. It's about $50 each. I don't know if your insurance will pay for it, having had no symptoms. She said, I'll pay the $50. I don't care. So they came in, we did the test. Both of them were positive, had 0 symptoms. So the other thing I'm doing is about 3 weeks after you test positive, test antibodies to see if you're immune. How long your immunity will last is unknown. but at least you're immune for the moment. And as time passes, they'll have more information about whether you should vaccinate someone who already had the disease and is immune. And as time passes, we'll know whether this is like influenza where you need a coronavirus shot every year, or is this something that you need once in a lifetime, 2 shots perhaps. The Moderna vaccine, I think, is 2 shots 4 weeks apart, and the Pfizer vaccine is 2 shots 3 weeks apart. So we're just learning as we go, unfortunately. Rita?
How many second-time infections have you seen?
I haven't seen that. I've heard about that. The testing, I had one person who had tested antibodies. His wife had had it, and then the other people in the family got it. We tested the wife and the daughter and him, all 3 negative for antibodies. So I said, I don't think you have it. You know, if none of the 3 of you have antibodies, she didn't have it, so it was a false positive. You get them both ways. You get false positives, you get false negatives. I had a brother-in-law who went to see one of my partners, and he said, well, I don't think you have it. Your lungs are clear. And he gave him a Z-Pack and sent him home. And my sister-in-law called 2 weeks later, and she said, hey, your brother-in-law is still sick. What should he do? I'm like, well, he should call me and tell me he's sick. I didn't know anything about it. And she said, yeah, he's missed 2 weeks of work. I was like, what? Why did he call? I've been around for 2 weeks. I was out of town the first time he went in to see my partner, but 2 weeks later, and he says, oh yeah, I've been hacking a lung out and this and that, and they're threatening to fire me if I don't come back to work. I said, well, come in tomorrow at 4 o'clock, and he probably had the coronavirus. He said, well, that's what I told him, but he didn't test me. And I'm like, well, I don't know how to explain that, but people make their best judgments, and we live with those. But I tested his antibodies. He was positive. He'd had the coronavirus. He was sick for 2 weeks. They were threatening to fire him for doing a 2-week quarantine, which is what they would have recommended had we known. So he basically saved everyone in his shop and the electrical, it was electric and heating and air company that he worked for, but he basically saved everybody in the shop from getting it by being home for 2 weeks. So they ceased and desisted of their harassment after that. So we should probably go, Colin, right?
Thanks, sir.
Okay.
I appreciate it.
Thank you. If you have other questions, I'll stick around.
Well, I think we just created the new definition of a big and popular topic, and that's one where we bump up against the hour and not a single person got up out of their seats to get back to what they were doing before. So thank you very much, Dr. Ludlow. Wonderful presentation. And unfortunately, we might have to impose